Here at UK. Our guest speaker today is Dr. Brian Fowler. Dr. Brian Fowler, he is the program director and oculoplastic specialist at the University of Tennessee in Memphis at the Hamilton Eye Institute. I was fortunate enough to work with him for 2 months during my 4th year away rotation. And for reasons I have yet to determine, he actually agreed to write me a letter of recommendation at that time. So thank you again, Dr. Fowler, for that. He unfortunately could not be here in person as he's coordinating their Cataractathon charity event, which is where they do free cataract surgeries for low-income patients. But he was able to speak to us over Zoom. And so with that, please welcome me in joining Dr. Fowler.
Thank you so much, Shane. I will say, it's very rare that I have a visiting student spend, and I'm sure you all have rotating students with you, and it's not a long time, right, that you have with them. And very, very rare that I have a visiting student that leaves such an impression on me that I do write a letter. And I will say, Shane was so good that he came back for a second month that I was very happy about. And he worked on research with me. And I ended up writing him one of my strongest letters I've written as a letter of recommendation. He is phenomenal. I'm sure you all know that and have benefited from that. I actually tried very hard to get him to stay in Memphis. So your all's gain our loss. But I'm excited to get the chance to speak to you all today. I'm going to be talking about thyroid eye disease and this paradigm shift in how we treat it. It's been the biggest discovery and change in the management of any oculoplastic or ophthalmic condition that I've seen during my career. I am the Vice Chair of Education at Hamilton Eye Institute, University of Tennessee, and the Program Director. I've been the Program Director since 2018. So let's get started. I don't have any real financial disclosures. I have been part of 3 studies with Horizon, looking at the use of teprotumumab in the treatment of thyroid eye disease, and we've now initiated and I've enrolled our beginning patients in the latest trial looking at teprotumumab in patients with chronic thyroid eye disease, meaning those that have had it and entered the quiescent phase for more than 9 months. These are my objectives. So for thyroid eye disease, this is not an uncommon disease, and many of y'all have seen it. Many of y'all have treated it. We have, over 1 million patients diagnosed per year. There is a female to male preponderance. Patients are typically in their 40s and 50s, although there are outliers here. I've seen patients that are as young as 3 years old with thyroid eye disease. It is the most common orbital disorder and by far and away the most common cause of exophthalmos or proptosis. It's also the most common cause for all the residents in the room of unilateral proptosis. So if you're seeing a patient, one eye is proptotic. This disease can be very asymmetric. And so one eye proptotic does not necessarily mean tumor. In fact, more common than not, it means thyroid eye disease. So the fundamental cause is, this is an immune system disease with autoantibodies that bind the TSH receptor in the thyrocyte. It's an IgG molecule, activates cell surface receptors. There is a genetic predisposition. There are environmental factors. This is the one of the only illnesses where I do discuss over and over again with my patients smoking. The other would be a patient that I'm going to be putting down a skin graft. And This disease has been extensively studied. If you look and even did a lit search, there's been many searches for other causes of environmental factors, and really the only one that comes up time and time again is smoking. And I see it over and over again in my practice that smoking does exacerbate this illness. It tends to make it significantly worse over time. The discussion of quitting smoking by us as physicians, especially when it relates to a specific illness, often can lead to patients quitting smoking. And I have had many patients over the course of my career over the past 9-10 years that I have brought up smoking and how it relates to their eyes and thyroid eye disease, and many actually of these patients end up quitting. And so I bring it up at the first appointment, and then I reinforce it every single appointment. And over time, you know, a significant amount of these patients actually quit. The orbit is a secondary target organ with Graves' disease. There are 3 components. Again, this is another area that has been greatly researched. This is heavily simplified, but there's an increase in adipocyte cells with increase in orbital fat. There's a T cell mediated immunity response with swelling and inflammation. And then there's proliferation of glycosaminoglycans, which leads to that increased thickness of the extraocular muscles, increased edema that we see with thyroid eye disease. So when there's been reviews of this, and one was a Mayo Clinic population study, you'll see that eyelid retraction is by far and away the most common finding on exam that we'll see. So if you see a patient with eyelid retraction, you know, there are a few other things that can cause that, but by far and away the most common would be thyroid eye disease. A significant number of these patients have proptosis, restrictive myopathy. You can see only 6% end up in a compressive optic neuropathy situation, and that is so it's a minority of these patients, but when it happens, it is a medical emergency. And part of what leads to that is extraocular muscle enlargement and compression at the orbital apex due to the enlargement of the extraocular muscles. That's about 55% when they've looked at those patients that have been imaged. And interestingly, 7% are euthyroid, meaning you're looking at a patient, they come into clinic, or you're seeing them in the hospital as a consult. They look just like thyroid eye disease. You get thyroid labs, and the thyroid labs come back normal. And 7% is a real number. This isn't, you know, 0.1% or something like that. It's an actual real number. And, you know, of those 7%, you know, some of them go on and develop abnormal thyroid labs later, you know, in true Graves' disease. And then some actually don't. And typically, the treatment paradigm, as far as the surgical options, is the same for euthyroid ophthalmopathy. So if you follow Rundle's curve, which for those of you have heard of that, there is a curve that this disease tends to follow. There's an inflammatory phase. It is highly variable. It can last anywhere from half a year to 2 years. And then there's a chronic phase with fibrotic changes, and this is over 5+ years, okay? And there's multiple long-term studies. The 2 most commonly looked at show that after you hit that chronic phase, where you're seeing a patient, they have proptosis, but there is not active inflammation, most of them, 72%, stay the same. 23% actually increase over time, their proptosis, and only 5% actually decrease. So I have seen patients that do decrease over time. and they get better. And those ones, they stick with you in your head. And I think they give us a bias that, maybe this happens more than we think. But when you actually look at the numbers, it's actually pretty rare for this to get better on its own. Most of the time, it will stay the same over time after they've passed through their active phase. So this is a diagram of Rundle's curve. And on the x-axis would be time. On the y-axis would be inflammation and proptosis. And so you can see that these patients, and I often tell them, you're gonna, if they come to me during the active phase, I say this can worsen over time. You'll tend to hit a plateau. And then there is a subset that may decrease a little. The inflammation will definitely decrease, but you'll not return back to normal or where you were pre-thyroid eye disease typically. It's similar to, you have the fire, a forest fire, a fire of inflammation, and that inflammation causes damage that doesn't reverse. The fire may be stopped, but the damage due to that inflammation remains. So we have a lot of treatment, that we do for this, a lot of treatment options. And the most important thing, and we as physicians, we don't want to miss this, and for the residents, but the most important thing at first is, assessing the severity and degree and whether there's risk to vision. Okay. And that can come in two forms. It can come in the form of compressive optic neuropathy. It can come in the form of exposure keratopathy, where on its most severe end can actually cause severe corneal ulcer formation. And so most common thing we do is we start these patients on conservative measures, artificial tears, lubricants, and then there is a role still for the use of corticosteroids, and I'll talk a little bit about that. And then there's targeted immunosuppression, which we're going to talk about. And then, there are multiple studies out there, and still a significant number of groups that use radiation, orbital radiotherapy to manage thyroid eye disease. And then we have surgical options, which I'll get to help treat this. So this patient that you see at the bottom left was a patient that I actually saw on call, and calling at the time I was a fellow, and calling Dr. Fleming, who is my preceptor here at Hamilton Eye Institute, and I said something.
Dr. Fowler, we can't quite hear you anymore. I'm not sure. There we go.
Can you hear me now?
Yes. Yeah.
Okay. I don't know what happened. I got a phone call on my phone, and somehow it switched. So just let me just pipe in if you can't hear me. Okay. So I remember calling Dr. Fleming and saying, this patient has something terrible going on. I actually thought this was going to be a CC fistula. And this patient has thyroid eye disease. So a severe inflammatory response, massive enlargement of their extraocular muscles with severe acute proptosis, chemosis, corneal ulcer formation. And so this is a thyroid eye disease can be highly variable. You can see patients that range all the way from an exacerbation of dry eye and maybe mild eyelid retraction, and that's it, all the way to severe proptosis, extraocular muscle involvement, compression of their optic nerve, and unfortunately, blindness in some of these patients. And then the second thing that led me down the path of this being something else is look at the other eye, essentially normal. And we really don't understand and know why an immune system regulated disease could result in one eye being so severely involved and the other not. But we see it time and time again with the asymmetry of thyroid eye disease. So with acute optic neuropathy, oral corticosteroids are a mainstay of treatment. And I've given you some of the dosing recommendations there. I will tell you typically what I do is I start prednisone. If they're in the hospital, I start methylpred, and I head to decompression urgently. Depending on the severity again of this, but within at latest 3 days, if very, very severe, we're going to the OR even that day or the next morning for orbital decompression. And the goal of that decompression is to not, in that case, and it will help relieve proptosis, but in the case of compressive optic neuropathy, you're trying to move the extraocular muscles that are enlarged away from the optic nerve. So your decompression has to be fairly posterior, to relieve that extraocular muscle compression on the optic nerve. If you picture, I know all of you have been told this possibly before, where you picture the orbit as a cone. The top of a big orange cone is the smallest diameter, and that's true of the orbital apex. And when you look at the scan, here you can see this is a pretty small area back at the orbital apex. So enlargement of the extraocular muscles, at that location, compress the optic nerve, and you end up with loss of vision. And so, the etiology as described, orbital congestion, enlargement of the extraocular muscles, you get compression of the nerve, and you look at the patient's nerve, and if it's acute, their nerve can look slightly edematous, it can look hyperemic. And I've even seen hemorrhages surrounding the optic nerve, which tells you, you are in trouble. You got to get moving very quickly. For orbital radiation, I will give you this caveat that this is not something that I use. There was actually a recent study that just came out showing the effectiveness of orbital radiation. To me, when I have treatment options that work other than radiation, which has a slew of side effects as far as the orbit, as far as the eye, I tend to move more towards those other treatment paradigms that I find work A, better, B, faster, C, with less side effects. But this is something that has been researched, and in certain areas of the country, even in Canada, this is a more common treatment, but it's not a treatment that I typically use. But I mention it here because it has been used in the past significantly, and it can be efficacious. The radiation technique, 20 gray delivered to the entire bony orbit, and it's fractionated over 10 days. So here's an example of a patient that received radiation. So patient in the acute phase of thyroid eye disease, you can tell the patient's severely chemotic, proptotic, and they receive radiation and helps resolve their inflammation. This patient obviously had a great result. For the active phase management, as I mentioned before, you're going to tell your patient you got to quit smoking. You are, and I don't mince words with this. I tell them you are more likely to go blind from this if you're smoking. And so that is a very important discussion to have. And I document it in every single note that I've had that discussion. The reason I document it is, we always document things for medical reasons, legal things, but more importantly for me, I document it so that I'm reminding myself that I had that discussion, and I'm going to bring it up again when I see that patient when they walk back in my office. I literally will walk in the room, and one of the first things I'll say out of my mouth when I walk in is, "How you doing with quitting smoking?" And I keep it light. I'm not like, the problem with smoking is very hard to quit. So I'm not judgmental with it. And I think that's a key. I keep it light, but I bring it up and I discuss the importance of it, and I'm direct. And then in the active phase, I'm considering interventions. And in the past, those interventions, if their eye was safe, if they're, as far as their vision, if they weren't in compressive optic neuropathy, if they weren't so severely exposed I was worried about ulcer formation, I typically waited a minimum of 3 months, but up to 6 months to watch for stability over time. Patients do have a better result with surgery if they're not actively changing and worsening. With the advent of teprotumumab, if they meet the criteria for that, I'm often starting them on that medication, and I'll get to that a little later in the talk. So in the congestive phase, in the or the chronic phase, this is when inflammation has died down. You're looking at your patient, your clinical activity score, which, for those of you that have learned about that or know that or treat these patients, you're often at a clinical activity score of 1 or less. I'm looking at rehabilitation of these patients at this point. How do I get them back to a place where symptomatically they're improved? And also importantly, and we can't lessen the importance of this, is where they cosmetically look better or more normal. For those of you that treat these patients, one of the biggest concerns that my patients have is the appearance change that they've had. And it is significantly psychologically burdensome to our patients when they've gone from, a certain appearance that's been their normal appearance their whole life, and suddenly they've got fat prolapse into their lids, they've got eyelid retraction, one or both eyes looks a little more bulged than normal. This really, really bothers our patients. And if you think about it as well, not that my male patients don't care, because they do, but there's a preponderance of females with thyroid eye disease and a presentation in the 40s to 50s, which now that I'm 42, 40s and 50s is a prime of life, right? And that's also young. Okay, so this really bothers particularly my 40, 50-year-old female patient that comes in. They're even often more worried about the appearance than they are about the symptoms they have, the severe dry eye, exposure, foreign body sensation, tearing, etc. So this is a conversation I have, with my patients of what are our goals, and there are multiple steps there to get them better, both symptomatically and as far as appearance. And for the residents, for your tests, for your boards, for your OCAPs, there's an order to which we do our rehabilitation. And there's a reason for that. So we do orbital surgery first, orbital decompression. There are multiple variants of that I'm not going to get into at this part of the talk. Then we go on to strabismus surgery, and then we go on to eyelid surgery, eyelid retraction surgery, et cetera. And the reason for that is Your orbital decompression is going to cause some patients to have worsened diplopia. Then they're going to go see their strabismus specialist and likely have strabismus surgery if they have diplopia. And then your strabismus surgeon, your inferior rectus and your medial rectus, your most commonly involved extraocular muscles. So we know that the inferior rectus also is very closely related with the capsulopalpebral fascia, the inferior oblique. And so there's going to be often an inferior rectus recession, which often makes lower eyelid retraction worse. So each step of the way, in this order, we're fixing the worsening of a problem from the prior surgery. And that's the reason for this. Now, not all patients need 3 surgeries, right? Some only need eyelid retraction repair. Some only need strabismus surgery. Some only need decompression, but we're looking at them as a whole and determining, which surgeries we think they'll need, and then, putting them in the correct order to give them the best possible outcome. Have been described 2 subgroups with this. And I do find that this is helpful. Not everybody matches, the perfect subgroup, but if you think about it this way, it is helpful to understand, what they're at risk for, how they'll look over time, et cetera. So, my group 1 patients have proptosis, but they have restrictive myopathy. So this is the group that has extraocular muscle involvement. You're examining them, you ask them to look up and their eyes go like that, right? They have significant extraocular muscle involvement. Their proptosis is often less severe than the group 2, which tends to be the more fat involving thyroid eye disease. So, and the reason for that is you've got these big, bulky extraocular muscles actually holding the eye back some. Okay, so your group 1, they can still, some of them can go on and have severe proptosis, but they tend to have less proptosis. But I'm worried when their eye looks very inflamed, you press on their eyelid and retropulsar globe, and it's fairly firm. You have them do extraocular motility, and they're definitely very restricted and up in superduction and in particularly abduction. Those would be the most common due to the inferior rectus and medial rectus involvement. I'm more worried about that patient. Your group 2 patient can have severe proptosis, but it primarily fat involving. You retropulsar globe, and they're not, they don't have increased resistance to retropulsion. They can have, some of these patients, they'll come in and I'll measure their Hertel and it's 31 and 32, right? That's pretty severe, but they often have 0 risk of vision loss. Their extraocular muscles aren't as involved. And so their risk of compressive optic neuropathy is very, very, very low. So breaking it into these 2 groups is helpful, and I do think about this when I am seeing my patients. So your group 1 patient, we start like we talked about, that order to surgery, floor medial wall decompression or lateral wall decompression. Here, and this is just how I learned, and it's not right or wrong which order you do or how you do a decompression. I tend to do a floor medial wall decompression, and then I move on to a lateral wall decompression if I need it. But there are many groups that advocate doing what's called a balanced decompression, where you do lateral wall and medial wall. And the reason for that is if you're doing a decompression of the orbital floor, you are likely, no matter how you do it, you are likely to get some hypoglobus. Okay, and so if you're doing a unilateral decompression, and you give a patient hypoglobus on one side, that is very noticeable. It's so noticeable that you often think when you first look at them that this is, strabismus. Then you test them and their light reflex can be equal, and it's actually the globe is sitting a little bit lower, and this is very concerning, to the patient. And so there are ways to do a floor decompression to help avoid that. Actually, what I'll often do is, if they have severe proptosis on one side, mild on the other, I will do a floor medial wall on the severe side, and I'll do a small orbital floor on the other. When they get, a millimeter of hypoglobus on each side, it's not noticeable, to the patient. And so that's a reasonable approach, but there's also quite reasonable to do, lateral wall first or medial wall and lateral wall. And then after that, if the patients have double vision, they go on to strabismus surgery, and then if needed, eventual eyelid retraction repair after that. So this is a picture you can see that I've diagrammed out of the area of floor and medial wall decompression. I decompress the floor laterally over to the infraorbital canal. I unroof the infraorbital canal, and that allows me to decompress that area without damaging the infraorbital nerve. And then I decompress the lateral wall or the lateral floor to the location of the lateral wall of the maxillary sinus. Once I see that, I know I can't decompress further because that becomes zygoma. That is very thick bone. There's breaking that is not something that is worthwhile to the patient. You could break it. It'd be a lot of damage incurred to do that, and it doesn't buy you anything extra. And then I'll decompress up the medial wall up to the level of just beneath the frontoethmoidal suture. That's important because the frontoethmoidal suture is above that is skull base. Right. If I decompress above that, I am likely to cause a CSF leak. And a CSF leak in these patients can mean more surgery by a neurosurgeon. If the decompression is done extensively enough above that, you can actually get the brain, to prolapse through the decompression, into the sinus, and that can actually stretch the anterior cerebral artery and actually cause a stroke of part of the frontal lobe. So this is not a surgery without risk, and that is by far and away the most feared complication of the surgery. And then the strut, the orbital strut, and that is a thicker part of the bone where the floor and medial wall meet, and I'll decompress that if necessary. I do the amount of decompression based on the amount I need. So, not all patients need as big of a decompression as you see here. Some only need part of the floor, part of the medial wall, and I leave the strut intact. Some need all of this. And typically in my hands, I'll get, if I decompress this entire area, I'll get about 5 millimeters of proptosis improvement with that. And so one important part of this for those that are learning, or, and I know if anyone's listening that's done a decompression, I leave part of the orbital floor, a shelf here. If I don't, there is, more likely to be more significant hypoglobus, and then even one of the other more severe complications where we worry about with this is what's called setting sun. The globe actually starts to fall into the maxillary sinus. The last part that I can do with this is I can open the periorbita between the extraocular muscles to allow the fat to prolapse through, which will also give me additional proptosis resolution. So this is an example of a patient with significant restrictive thyroid ophthalmopathy. who underwent decompression, and you can see, the significant improvement in their proptosis, especially from this bird's eye view here, where they're essentially equal now, and don't have that exposure keratopathy. This is another example of a patient with significant proptosis, and you can see following decompression, resolution of their proptosis, and the hit home point here is not only are their symptoms better, their vision protected, but this gentleman now looks normal. So you can imagine, this patient comes into me and says, I look terrible. People are staring at me all the time. Actually, with men, you'll often hear, my wife keeps telling me I have to go see the doctor and get this figured out. That's why I'm here. They're complaining about how I look, and so, this gentleman's very happy by the end, with essentially a normal appearance following decompression. And this surgery still has a utility, even though we have a significant improvement in our management of thyroid eye disease with teprotumumab. I still do decompressions, albeit less. So this is a patient that ended up receiving a 3-wall decompression, floor, medial wall, then later lateral wall decompression, had strabismus surgery. Importantly, some of these patients have malar hypoplasia. If the cheekbone is depressed, these patients have, in relative position, compared to that, the eye is even more proptotic, more exposed. Dr. Fleming used to say, when he saw a patient with this, he would say, when God was handing out cheekbones, he forgot to give you some. But it's not always stuck with me, but we can actually use implants to augment the maxilla, which will further help the position of the lower lid and the globe relative to that, which not only rehabilitates the patient to look more normal, but also lessens their relative proptosis and exposure. And so in this patient, we have a group 2 patient. You can see, and we don't see a lot of active inflammation, but we see significant proptosis. This patient, I did lateral wall decompression. You can decompress the orbital fat, may remove some of the fat, malar augmentation, eyelid surgery, and you could see, she ends up in a great place. Her symptoms were actually pretty mild. Okay, she had mild, exposure symptoms, but not severe. She had no risk of vision loss, but with reconstructive surgery, we're able to get her to a place where she feels like she looks normal again. And one of the funny things when I was putting these together is, looking back, is how many of these patients in their first photo are not smiling, and in their follow-up photo in the office are smiling for the photo. And I was, interested to see how often that happened with the pre-op and post-op photos of these patients. So here you could see where we decompress the lateral wall. I often take part of the rim off, and then I actually put it back on at the end, and we can decompress back. I use a drill to do that. This is an intra-op photograph of that. The lateral orbital rim has been taken off, and I've dissected back along the lateral wall and decompressed part of the lateral wall with a drill. And this is a patient pre and post-op for lateral wall decompression. If needed, when I'm there, I usually, when I do this surgery, do it one side at a time. But I can actually address, because of where I'm placing my incisions for the lateral wall decompression, I can address their eyelid retraction if it's needed partly at the same time with a upper eyelid crease incision laterally. This is an autoimmune disease. Okay, so when you think about it, surgically, we are just taking a hammer, right, and treating the problems caused by the disease, but we're not treating the disease process at all. It's the primary thought process here that is the way in which our treatment paradigm for thyroid eye disease is changing. There are many factors at play here. I won't go through all of them, but it is an autoimmune disease, and if we can treat it with targeted therapy, we can change the course of disease, and we can actually lessen the amount of surgery that we need in these patients. So this was the original article out of the New England Journal of Medicine looking at teprotumumab. We recently had Ray Douglas come and talk to our department, and he is an oculoplastic surgeon. He's now in California, and he worked with Terry Smith, who's an endocrinologist. Actually, when I went and interviewed for Oculoplastics Fellowship in Michigan, it was the only interview I ever have done for ophthalmology or oculoplastics where I interviewed with an endocrinologist. He had a faculty appointment at University of Michigan with ophthalmology, and he did 20 plus years of research on this prior to this ever becoming, a medication that could be utilized to treat thyroid eye disease. I think this is so important to understand, as especially to the young people in the room and the residents, is a lot of the greatest discoveries were and treatment changes and things that come about are not things that happen overnight, and they're not there's not a quick fix to it. It wasn't a eureka moment and suddenly everything's, you come up with the idea and you got a drug to market in 2 years. He faced many hurdles with this. So did Dr. Douglas. In fact, in the beginning, no one believed, him that this pathway was even legitimate. And so, it can be a lot of work and a lot of failure along the way in order to get to a place that actually changes the world. And these two did, in fact, change the world. And so you could see I've got listed here some of the next studies after that landmark study looking at the treatment of thyroid eye disease. And these, importantly, we're looking at the treatment of active thyroid eye disease, those that have active inflammation. And that is where we ended up with the FDA approval for teprotumumab, was for active thyroid eye disease only. This was probably the coolest. I've done a lot of research, but this was the coolest I've been a part of. This was a double-blinded. These were all double-blinded, placebo-controlled trials, multi-site, and this last one that we did, we ended up being that we enrolled the most patients, and it was amazing because we say blinded, but we really weren't blinded from the standpoint of I didn't know if they got medication or placebo on the front end, but I can tell you 100% of the time when my patients came back, I knew whether they got the medication or not, because the change was so dramatic. Doing that trial was moments that I will never forget. Watching this happen without surgery is absolutely incredible. So this is IGF-1 receptor monoclonal antibody. And our trial included inclusion criteria was new onset, active disease, CAS score of 4 or greater, and they had to have controlled thyroid disease, meaning they were seeing their doctor, whether it's an endocrinologist or primary care doctor, and they had to have thyroid labs that were within a normal range. And then importantly, excluded optic neuropathy. Those patients need urgent decompression. We can't wait around for a medication to work. And then excluded was previous high dose steroids, which is interesting because for those of you that prescribe this medication, we excluded it. It was excluded in order to not have confounding factors on this working. But now these insurance companies have picked up certain previous studies, and the number one reason I'll get a denial for teprotumumab is I haven't tried steroids, right? So I literally have to document that I have a contraindication to steroid use, or that I have tried steroids, or I am almost 100% guaranteed to get rejected for the medication. So insulin-like growth factor 1 receptor, it's overexpressed on fibroblasts, and signaling of fibroblast immune cells mimics what we see. And we see antibodies to these receptors in Graves' disease patients. And this is just a graph that you can see showing, that you can see on the y-axis, the percent of positive IGF-1 expression, Graves' disease versus control. This is pretty dramatic, right? And same over here on this graph. So IGF-1 receptor is overexpressed on our patients with Graves' disease. And so, people have talked about this as a term that's been out there, right? Kissing cousins, IGF-1R and TSH receptor. It is, they're very likely, related. And that is likely the link and the reason why we're seeing, effects both at the level of the thyroid and at the level of the orbit. There are multiple autoantigens likely necessary for manifestation of disease, and that is why we probably see also this high variability between patients. And then, some of the results of this trial, you can see on the y-axis change from baseline. That's millimeters of proptosis. You could see our patients that, and then x-axis over time. You can see our patients that received teprotumumab, ending up somewhere along an average of 4 millimeters of proptosis resolution, after teprotumumab. And so again, you can see that dramatic improvement, this is this moment again where I'm doing this trial and I'm seeing these patients come in and I'm going, oh my gosh, holy cow. That first slide, sorry, was clinical activity score over time. And then, we looked at quality of life with a survey with the patients, and you could see a significant improvement in the quality of life, also all very significant in those patients that received teprotumumab. This was the part that was interesting to me. I don't know why, but in my mind, I didn't expect patients' diplopia to necessarily get better. But you can see a significant percent of patients did have a resolution of subjective diplopia. I mean, this number is somewhere up around the 70% range, and very, very significant. So we looked at slides earlier where I had pre and post-op photographs. And in this patient, they received no surgery. The only thing they received was teprotumumab, and they go back to looking normal. For those of you who don't know, teprotumumab is a treatment given, for a total of 8 cycles. It is given by an IV. So you have to have them go to an infusion center, and it's every 3 weeks. So it's a total of a 24-week treatment cycle. So my prediction is over time, these patients will not require major surgical management of this disease, which is incredible. It's partly, I joke about this, it's not really true, but you feel like you're kind of putting yourself out of business a little bit. I did a lot of decompressions before this came out. Sometimes often as much as 1 per week. I have a very busy practice and very, very high thyroid referral network. So I see many thyroid patients, and I'm definitely, way down, probably doing 1 decompression now a month or less. Side effects, and this is important, okay? And this is still being worked out. And when I went through the trial, I saw very minimal side effects. And the thing to know about an FDA trial is you don't have huge numbers of patients, okay? So some of the less common side effects, you may miss. And after the drug hits market, some of those start to come out. But one thing we are seeing is a recurrence of thyroid eye disease. I've always told my patients, multiple studies show this, but there may be approximately a 10, sometimes 15% recurrence rate. We've taken them through all the surgeries, all the treatment. They've entered the chronic phase, and for some reason they reflare. And that number it's my prediction is going to end up about the same, 10 to 15%. And multiple studies have been done or are being done showing around there. But these patients, I've had multiple patients go through two rounds of teprotumumab. Blood sugar elevation. This is not to be taken lightly. Most get a slight bump. Patients with brittle diabetes, with diabetes that tends to fluctuate significantly. I've had a patient, I've now treated over 70 patients with this medicine. I've had a patient develop hyperglycemia to the level of blood sugars in the 400s and 500s, requiring hospitalization. Okay, so my conversations with my patients as I've seen that have changed. Right, I talk about those side effects. I talk about the importance of regularly seeing their endocrinologist, the importance of letting me know if they have a side effect, because we may need to stop the medication or delay the next cycle. And there are options to decrease the dose. And, we started with a dose. It's like you're taking a dart and throwing it trying to hit the bullseye. But some of that initial dose is based on, previous information. It's a little bit of a guess, honestly. And so, we are looking at, can the dose be lower and still get the same result? And conversation with Dr. Douglas, he actually feels that this is true. And he now, with his patients that have coexisting diabetes, starts them and keeps them on a lower dose than the classic doses of the studies. Most common thing I see is irritable bowel syndrome exacerbation. People describe upset stomach fairly frequently. And then the one that's really being teased out, that's been looked at extensively, and I've had 2 patients with this where, I'll hear frequently from patients, my hearing's a little muffled, then they'll come off of teprotumumab and it goes back to normal. But I have had 2 patients with severe hearing loss that required, moving on to hearing aids, and still with difficulty with their hearing, even after cessation of the medication. After discussion with Dr. Douglas when he was in town, there is a fat pad associated with and near the middle ear. And it is felt that with teprotumumab, that fat pad is actually getting smaller, much like the fat in the orbit. And that is one of the reasons that fat pad helps maintain the functionality of the middle ear. And when that fat pad gets smaller, it actually does affect hearing and results in the most common complaint, which is, a muffled hearing, or it sounds like I'm sitting on a runway at the airport. Our latest study that I'm involved with, they actually, when I started enrollment, they sent me an audiogram, and we're now audiogramming every patient at the beginning of the study and then at multiple endpoints. This is the questionnaire that I created, and the reason I will tell you 100% for the questionnaire. So if you want this, I can send it to you, is I am trying to avoid the denial of teprotumumab. These are all the questions that they want to know. Typing them into my note or even creating an auto-saved template is difficult. So I created a sheet for every one of these patients. I circle the things, and this goes with, the initiation of the medication for approval. And the nice thing is Horizon's actually very helpful when it comes to helping get these patients approved. I discussed earlier, there was some new literature out on orbital radiation. This was discussed at a recent meeting, and there is still a group that feels strongly that this is a mainstay of treatment. There is still a group that feels like Tepezza is not the answer. So and like a lot of illnesses, there are multiple treatment paradigms that work, and you have to be cognizant of the side effect profiles of everything you do, of the possibility of potential outcomes, and you need to make a decision for your particular patient what the best pathway is. I got a patient with diabetes and milder proptosis, but still some inflammation that may possibly meet criteria for Tepezza. I'm probably not going to go Tepezza route. And let's say they have pre-existing hearing loss. I'm probably not going to go that route. I'm going to go back to a more classic approach. Recently, we published in Ophthalmology on teprotumumab. You can look up these trials, but it's looking at the durability, how long this medication lasts, if we need retreatment, what are the outcomes there. And then currently I'm doing a trial on chronic thyroid eye disease, those that have had it for more than 9 months, those who have a clinical activity score of 1 or less. So our chronic disease patients, the question is whether this medication will work at lessening proptosis. The inclusion criteria is they have to have significant proptosis. Will this medication treat proptosis in the non-inflamed quiescent patient? And I'm now, enrolled, I think, as of last week, the 4th patient. This is just getting, really up and moving and underway. There is a horizon of new classes of thyroid eye disease medications, particularly IGF-1 receptor monoclonal antibodies. I've been reached out to by multiple of these companies. One is oral, importantly, which may be a big improvement than dealing with the issues related to infusion centers and travel for our patients. The other is IV or intramuscular, both from Viridian, 2 different little medications there. I do believe over time we're going to have a group of medications in this class that we can choose from. They may have slightly different treatment paradigms. They might have slightly different efficacy, and they may have different side effect profiles. The more medications we have in this class, the more options we have to choose the right one, for our patients. So that is the entire talk. This is an exciting time in the world of thyroid eye disease. It's exciting mostly, especially for our patients, This is a treatment option that did not exist before that works really well in the right patient. And in the land of all of medicine, we're seeing this advent and takeoff of monoclonal antibody treatments for numerous diseases that are targeted specifically to the problem in that disease. Even some having treated cutaneous melanoma. There was a time period where metastatic cutaneous melanoma was guaranteed to be a death sentence, and now there are treatments for that within this same type of class of medications of monoclonal antibodies. So it's an exciting time in medicine, where we're actually looking at treating the specific molecular causes of these diseases, which should improve patient lives, have lower risk to the patients long term, and as a physician, that really has seen the gamut with thyroid eye disease. It's really exciting for our patients. So I want to thank everybody for giving me this opportunity. I'm sorry I couldn't be there to actually meet with you all in person. I would have loved that. So we'll have to take a rain check on that. I'll have to meet you at another time. But thank you, and thank you to Shane, for inviting me. I'll open the floor for any questions.
Hey, so I know that you mentioned in the trial that you excluded patients that had undergone steroids in the past. And then you said that the insurance companies are now requiring you to show inadequate response to steroids prior to starting Tepezza. In your practice, do you feel like you've seen a different level of benefit or a similar level of benefit for patients that are taking Tepezza after already failing steroids versus in the trial when they didn't have steroids previously?
Yes, that's a great question. I've a lot of my patients have been on steroids even before sometimes they show up to me, and the results with Tepezza look exactly the same. The issue with this is there are of like white papers and things like that are treatment paradigms. These are the types of things that insurance companies look at, and they're outdated in this area in thyroid eye disease. So they're pulling them up, and it's saying one of the mainstays of treatment is prednisone, right? And I even get into these discussions doing peer-to-peer phone calls. Steroids are not a good long-term treatment of thyroid eye disease. So that's one of those things that's somewhat frustrating, right? That I'm even having to start some patients on steroids knowing they won't work well just to get them to Tepezza. Or I'm having to I have to come up with things of reasons it's a contraindication. I mean, I will literally write, patient was on steroids 7 years ago and had severe psychological stress. I never lie, okay, in my note, but if I will try to find any reason I can of why in this patient the steroids are contraindicated. Obviously they're the more obvious ones. They have diabetes, right? They have, whatnot. But that part of it's, it's crazy to me. But the answer to it is, new, white papers need to be written showing actually what the true treatment algorithm is for thyroid eye disease, which will then shift the insurance market. And of course, the insurance companies are looking to reject. This is a treatment that's $14,000 per treatment times 8. And then the infusion center is charging them, for the treatments they do while they have the patient there and for the management of the patient. So I've had a patient bring me a bill showing me their insurance company had paid $480,000. So we need to be, logical about understanding, yeah, they're going to reject some, because of that.
Any other questions?
Dr. Fowler, thank you for the talk. Is much appreciated. I'm one of the PGY2 residents. I was just wondering, when the trials were completed, is there any longitudinal follow-up to know if these patients are having any recurrence?
Yes. So if the last paper I presented, has a follow-up period, and the recurrence rate, is ending up somewhere. And my patients were actually actively putting together a paper, on this that's retrospective, looking at the whole group of patients, that I've treated. But it's somewhere ranging in the 10 to 15%. Interestingly, of those patients, when they're treated with teprotumumab again, they get the same result, okay, with retreatment of, the significant reduction in proptosis, but, certain patients, you can't do that, right? If they had any side effects that were significant, we're going to avoid doing that. But in the ones that don't, the results with retreatment are still, very good. So I do, if I get a patient and I have a handful that recur, I do, work on getting them approved again and back through Tepezza. In fact, Wednesday, I saw one of my patients that's had treatment twice and has recurred again. Okay. So, as this is a newer medicine, the length of time, the duration of reflare since treatment, that length of time is still short. So part of the answer to your question is we do need more time, right, to see how many of these patients actually are truly going to recur, over time, over years.
Well, thank you very much, Dr. Fowler, for coming and speaking with us. Over Zoom, it's kind of hard, but I promise you did get a few chuckles throughout the presentation. I know we were on mute, so you didn't get to hear them, fortunately. But we also have something for you. I don't know if, Maddie, if you have an example, I don't have it here with us, but we have an eye chart with a lot of different things involving Kentucky that we're going to send to you out there. And so I'll get the
Awesome.
address that you'd like that
Here, I
from.
can show it. Give me 1 second.
Okay, great.
All right, this is what it will look like. It might be backwards, but oh, this is my face. Hold on. Will it show? Oh no. Hold on. Oh, there we go. Kind of.
There we go. Yeah.
Ah, I'm trying.
Yeah. What some of our patients see.
Oh,
Yeah.
no. I can't.
Yeah, exactly. Eye chart with cataracts.
There you go. It has little Kentucky things on it. I'm trying.
That's
Sorry.
awesome.
We'll have that sent out to you. Thank you again for coming. We really, really appreciate it. And my family and I are hopefully going to come down there to come see you at some point. We just had our 5th. We used to joke about how we both had 4. So I don't know if I beat you now or not, but
You did. I got 5. So we're
okay.
yeah.
Even then. All right. Thank you again.
Absolutely. Thank you so much. Thank you so much for having me. Y'all have a wonderful weekend.
You too.
Thanks.